Hotbed Talk.
So it's my pleasure next to introduce David Storey. I think most of us know David quite well. He's a bit of a fixture in the perioperative circuit. He's the Foundation Chair of Anaesthesia, University of Melbourne, and the Director of the Anaesthesia, Perioperative and Pain Medicine Unit at the Melbourne Medical School. He's basically a past chair and current member of the ANZCA Clinical Trials Network, and he's got 30 years of research behind him. So we've asked him to talk to us about prehabilitation in the frail. So thank you, David.
Thanks a lot, Ming. In terms of this topic, Ming just mentioned I have 30 years of experience. My early work was actually in exercise physiology, so I come from that background. And I've said at a previous meeting, I was actually a resident for Paul Alder and a registrar for Paul Alder, which was a very enlightening experience. The other good thing we've done at the University of Melbourne is we now have a Centre for Integrated Critical Care, which combines anaesthesia, intensive care and emergency medicine. This is one of few such major academic units in the world, and we hope that this will help very much in furthering areas of critical care, but particularly perioperative medicine. I'd like to acknowledge the traditional owners of the land. I have no particular financial conflicts of interest, but probably lots of academic ones. So this is how we'd all like our elderly patients to be, and I think this was mentioned earlier. When we come to rehabilitation, I'll say up front, I would argue on the balance of probabilities. I'm married to a lawyer, so I use those sort of phrases. The balance of probabilities that prehab is a good thing. As a clinical trialist, I would argue we cannot say beyond reasonable doubt that prehabilitation is an important thing. We have shown frequently in clinical trials, I'll talk about one or two on Saturday, where things have not gone as anticipated, and we need to be very mindful of that. I would also argue that the best available evidence is a large pragmatic trial, but I recognise they are hard to run, but we are very lucky in Australia and New Zealand that we have considerable national, international collaboration in conducting such trials. Now, this is a meta-analysis from the surgical literature, but just reinforces what the previous speakers have said, that frailty, no matter how you view it, is associated with increased hospital mortality, increased one-year mortality, and I think importantly for patients, greater likelihood of increased admission to supported services and nursing homes. So if we look at the big questions, I'm going to emphasise prehabilitation, but what is the best way to identify and quantify frailty? And I think quantity as well as a dichotomous yes or no is really important, particularly as we look at risk scoring. What is the best way to adjust our risk assessments as we incorporate frailty? What are the right surgical interventions? The previous speakers have talked about the surgical plan. The prehabilitation, I'll talk about post-operative care and limits on medical treatment. What are the goals of care? Those really important questions. But also, what are the outcome metrics we want to measure? Complications, a hospital length of stay, readmission, a metric called days alive and out of hospital or days alive and at home, quality of life and supported care. So, how to identify and qualify frailty? The first is end of the bed. We need to stop doing this, no matter how clever we think we are. Dodgy phenotypes. So this was mentioned, the idea that you have an overall phenotypic component which has elements of inadequacy, and Bobby Jean touched on that and I'll come back to that. And then cumulative deficit. So Rockwood is from Canada, is the person who's really pushed this particular model. But remember, this is looking at exactly the same patient. So we've got different ways of considering and quantifying and estimating frailty in exactly the same person. So this is the clinical frailty scale that is used very widely. I think the fundamental components of this are activities of daily living. So the instrumental or intermediate ones. So banking, transport, cooking, cleaning, and the basic activities of daily living. And the group we're probably most interested in our elective surgery is really the middle group. If you remember, the vast amount of surgery for the elderly and frail is emergency surgery, whereas elective surgery is about the less frail and perhaps not quite so old. So this middle group of apparently vulnerable, mildly frail, moderately frail, and it's all about, in this scale, activities of daily living. So our intensive care colleagues are starting to use this routinely. Some of the intensive cares in Australia and New Zealand now routinely measuring this in their patients because it is reportable by others. And I think that will be a useful metric, and it's one I think we should consider. Now, this is part of an international collaboration. There are names you'll recognise: Paul Miles, Mike Grocott, who's here, looking at the outcomes in perioperative medicine research. It's called the STEP, or Standardising Endpoints in Perioperative Medicine. I think it also will apply to how we understand practice. So these are the patient-centred outcomes, patient satisfaction, quality of life, disability-free survival, return to normal functioning. I think that's one we need to consider more and more, what the patient expects to. Functional status, the 6-minute walk test, which I'll mention again, and then home days. And again, this idea of days alive at home, combining mortality, length of stay and readmission. And I would argue that 90 days is probably about the right compromise time. So there are different ways to view frailty, and I apologise that this is hard to read, but the major points are that this is a more micro level, this is a cellular level, and there are different ways to think about patients. There's the macro way we look at them, but the thing that really drove this home to me was I do liver transplants, and we have had some patients die on the table, and they just flame out. Why are they flaming out? Partly because they've just got general cellular deterioration and mayhem. So this is more a cellular mayhem view of frailty. But importantly, in the red box is both physical activity and nutrition. So this is, the core of Prehab, the belief that you can modify frailty with Prehab. And so we're talking about stress, such as this elderly African-American gentleman helping a Texas policeman with his inquiries. This is from Freed. So Freed is the person who came up with the phenotypic approach. And the Johns Hopkins approach that Bobby Jean mentioned has an association with this. And this is much more macro. But I have emphasised that you've got VO2 max, so aerobic capacity, CPET, but also nutrition. Hidden away in there also is strength and power. And I think as we look at prehabilitation, and the people heavily involved in looking at this, we aren't just looking at aerobic exercise, we're also looking at strength exercise and nutrition. So bringing these all together in the time prior to physiological stress, but probably also after physiological stress. So Prehab is preoperative optimisation of functional capacity before an anticipated stressors such as major surgery with the intent to improve postoperative outcomes. So here we have Jackie Chan, clearly an elderly Chinese gentleman. So the frail are already behind. If they come in from emergency surgery, they're even further behind. All patients who undergo emergency surgery are at greater risk of adverse outcomes. So the frail are behind those again. So if we look into community studies, so this is a meta-analysis looking at what we would call prehabilitation, but in the community, not around the time of surgery. So 14 studies looked at diet and exercise, but they had different definitions of frailty, and they found some evidence of benefit of exercise, but diet was less clear, and they couldn't do a meta-analysis. And this emphasises one of the important points in this, is you want to look at the patients who may benefit. You want to get value. You want to improve the group who will benefit from the improvement. So the very old and the very sick may not benefit from any of this. The very young and the very fit don't need it. We need to identify the patients who will benefit from prehabilitation, assuming that prehabilitation works. So when we do studies, that's the group we need to study. This is the concept of a care bundle. So the NHMRC, the idea is you have a set of evidence-based practices performed collectively and reliably, well established, and combined in a protocol, responsible to the whole clinical team. And the archetypal one, I think from Bobby Jean's university, or that area of the world, is in central line placement. So they introduced a bundle of care looking at reducing catheter-related infections for central lines. So again, cohesive set of steps, often about 5, so not a massive number, not like a massive checklist. They're evidence-based, ideally from randomised trials, and they can be easily measured, and they occur at a specific time and place in the process. So Bernard Riedel, who's known to virtually everyone here, from Peter Mack, has conducted a systematic review of multimodal, so the bundles of care, prehabilitation, in gastrointestinal cancer surgery. So if we remember that colorectal cancer is the most common cancer affecting men and women, I think that's the group we're particularly focusing on. We've already talked about issues such as anaemia in both the elderly and colorectal cancer patients, and this was published this year. So again, these elements of prehabilitation. So clinical, optimising, we've talked about comorbidity, we've talked about anaemia, glucose control, physical activity, so strength training, aerobic, nutritional, again, Bobby Jean covered that very well. Educational, so what is the patient expecting? How do the ideas of depression and mental health came into it. Anxiety, smoking, alcohol, drug cessation, and combining all of these together in the optimal bundle. So the intervention, so exercise, nutrition and nutritional optimisation, haemoglobin and iron, as Bobby Jean talked about, psychological optimisation, again, as Bobby Jean talked about. The outcomes, so morbidity, mortality, length of stay, and this sort of more controversial area of 6-minute walk test and CPET outcomes, and whether the argument, and we could probably have a debate here and now about, are these important outcomes or are they surrogates? And I'm an agnostic on that. Quality of life and biomarkers such as haemoglobin, how anaemic are they afterwards? And then the compliance with prehabilitation. So Bernard and his group recognised 544 studies, 20 were included. So 2 trials, very small numbers, had multimodal exercise, nutrition, anxiety management, and there were number of unimodal trials, exercise, iron, nutrition, perioperative smoking cessation, with enormous variation in compliance. And so, again, lack of adequate power. They were just too small to really answer even the questions I think they were wanting to answer. And again, Bernard and his group could not do a meta-analysis because of the degree of variation, both in what was being implemented and the outcomes measured. So, but they found that exercise improved fitness. So I think we can be reasonably confident that if you do exercise patients prior to that, they will be fitter during the perioperative period. And Bobby Jean talked about that. Nutrition. So two studies showed no benefit and 2 studies found fewer complications. Anemia. 3 or 4 studies demonstrate a trend towards better haemoglobins afterwards and decreased transfusion. One of the issues with patient blood management studies is often the transfusion is seen as the endpoint. I would argue that as a surrogate. The transfusion itself is not an endpoint. The complications and mortality and length of stays are. So smoking cessation, benefit, but the more effort you put into it, the longer the duration of smoking cessation. And again, multimodal, very small numbers, that they found improved walking capacity, but they're underpowered, so inadequate sample sizes for complications and hospital length of stay. Now, this is a study from Italy. They used yet another frailty scale. As Ruth mentioned, there are many frailty scales, but they had a pre and post design, so it's not a randomised design, but they identified frail patients using their own approach, and they found that they were in their 70s, they're a reasonably healthy group, but they're having major surgery, esophagogastric and pancreatic cancer surgery, these major complications. And so their prehab was nutritional support for all patients, irrespective of their nutritional status, deep breathing type exercises, and then moderate intensity walking. And because they're Italians, they were smoking interruption, not smoking cessation. But what they found in this non-randomised, non-blinded trial was that there was a signal. 30 days mortality was improved, complications were fewer. So this is, in terms of pilot work or supportive work, gives the vibe, to quote from The Castle, the movie, that we're heading in the right direction in this sort of approach. So I just want to talk about the protocols for several studies. This is one from Singapore. So the important thing is there are randomised trials going on. So the evidence base will improve. So this is a single-centre randomised study for prehabilitation in the frail and elderly undergoing abdominal surgery. So the group we really want to focus on, the older people, the frailer people having major surgery. So these are the Freed criteria for the phenotypic approach to frailty. And again, we have frail, pre-frail and frail. And, you're looking at elements of the patient, and Bobby Jean talked about the dynamometer and those sort of things. But it's a bundle, physiotherapy, so respiratory training, nutrition, but a cognitive exercise, playing cards. So again, this issue of a bundle of care, several things to do. And the primary outcome is the post-operative length of stay, and then other things such as mortality, ICU admission, ventilation, and other cardiovascular. And they're looking at one of the actually Australian-produced post-operative quality of recovery scores. This is another study called the Prehab study, and you'll find one of the things I'm going to say is stop calling Prehab studies Prehab. It doesn't work anymore, and I'll show you why in a moment. But so preoperative prehabilitation, hospitalisation after coronary bypass. So this is cardiac surgery rather than non-cardiac surgery. But again, an element of standard of care, and then a prehab intervention that includes exercise in particular, and that's what they were most interested in. And then their hypothesis is that prehab reduces the proportion of frail older patients requiring prolonged length of stay, which they define as greater than 7 days. So 65 years of older, elective, having standard cardiac surgery, using the clinical frailty scale. So they're including the ones, that middle group I was talking about, those who are frail but leaving out those who are extremely frail. And the primary endpoint, as I said, was length of stay. And they're assuming a 20% absolute risk reduction in the number of people staying longer. And again, they're using the freed approach to diagnosing frailty. This is another prehab study. Same acronym, different study. And it's a protocol for a randomised trial, people living with frailty having cancer surgery, so close to what Bernard was looking at. So home-based exercise using the clinical frailty scale again as a screening exercise in people aged over 60. And I think that's something we need to increasingly think about. What are we going to use to screen? And I think the clinical frailty scale may be the way to go. Ruth will have definite opinions about that, as will Bobby Jean. So the exercise and prehab will consist of 3 components: strength training, aerobic exercise and flexibility. So this idea that it isn't just about aerobic training, it's about strength and flexibility as well. And their endpoint is the 6-minute walk test post-operatively, with the hypothesis being that their program will improve that in this vulnerable group of patients. Now, this is a study where they actually have completed the study and they've looked at the effect of exercise and nutrition after people are having esophagogastric cancer surgery, so major surgery. You'll see that the patients are in their 60s, but the majority of patients are actually relatively well. The ASA, half of them are ASA 2, some are ASA 3. And I think importantly, that's worth considering, but that is consistent with patients having surgery of this magnitude. And the most important thing really is on the left-hand side. So this is the 6-minute walk test, entirely consistent with Bobby Jean's slides, that they found that there was a peak preoperatively in the 6-minute walk test that stayed above 0 in the intervention group, and a decline in the 6-minute walk test and presumed aerobic capacity in the control group. And I think this is evidence that this approach doesn't improve patient exercise capacity. The question is the clinical importance of this, and I think that's an important area for debate. So conclusions. There are a lot of trials in progress. The question is prehab, what type, what bundle, what dose? We need to think of this as a dose as well as the type of intervention. Prehab probably improves post-operative exercise capacity. We need to consider patient-centred outcomes. You could argue that length of stay is not adequate as a patient-centred outcome, would be my argument. 6-minute walk test may or may not, depending on how you see that relates. Paul Alder, I think, was someone who used to say that exercise capacity is lifestyle, and I think there's a lot of truth to that. We've got to stop using prehab as the acronym. That's now been used by at least 2 studies, so that's out the door. But there's enormous variations and outcomes. We need to try and standardise what we're doing, particularly if we're heading towards a large international, finally get the answer type, 8,000 patient study. We need to have these standardised so we know what question to ask and we know what endpoints to measure. So, but not all elderly are frail, as Ruth was saying. The important thing is that perioperative medicine is a team sport, and I mentioned this as an academic. Clinical care, research, teaching and engagement. Engagement meaning working with patients, working with government, working with hospital administrators. So it's about physicians, surgeons, intensive care. In Australia and New Zealand, we're very lucky to have, in contrast to the United States, extremely strong government-supported community practice. And I think that's one of the major differences and advantages that we have. We need to consider very broadly other allied health specialties, nursing, physiotherapy, pharmacy. The universities will have a major role to play. But the new professional allies, biostatistics, health economics, health informatics, and how we can use this not only in research but also in our daily practice. We have to work with hospital administrators. We have to work with the government. But it's all about patients. We need to ask the patients what's important to them. I had a discussion with a colleague from Stanford, and we were going to talk about doing a data study called Worsen Death, looking at who is admitted to a nursing home. We know that in the Australian setting, a lot of patients, the last thing they want to do is be in a nursing home. My own parents are like that. So we've got to work with patients. And, of course, anaesthetists. Thank you.
Nick Majerison here. On August the 11th, 12th and 13th, the American Association of Nurse Anaesthetists will be holding their annual Congress. Top Med Talk will be coming to you with live updates from the meeting as it happens. We will be interviewing thought leaders, academics and prominent practitioners for 3 days of discussion and debate. The opioid crisis, enhanced recovery, innovations in anaesthesia and much, much more. Guests will include the president of the AA&A, Gary Bridges, Lynn Reid and Lorraine Jordan, to name but a few. To get ahead of the curve, why not listen to some of last year's podcasts from the AA&A? Simply go to topmedtalk.com and type into the search engine AA&A. Pop that in and you will find our output from last year. In the meantime, of course, if you want to find out more, the American Association of Nurse Anaesthetists are holding their annual Congress August the 11th through till the 13th. Go to topmedtalk.com for more details. And while you're there, make sure you subscribe to Top Med Talk and, of course, that you've joined us on social media. That's topmedtalk.com.